Cancer of the stomach, colon, or pancreas can be frightening, but knowledge brings hope. Dr. Prem Sobti from Carle Health joins me in studio to discuss the rise in GI cancers, how they're treated, and the support available for patients every step of the way. That's what's next on Being Well.
This is you, and you are why we do what we do. Because the way you feel matters. Sarah Bush Lincoln, trusted, compassionate care.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
Carle is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carle is always at the forefront to help you thrive.
Thank you for joining us for another episode of WEIU's Being Well. I'm your host, Lacey Spence, and today we are welcoming in another new guest to the show. We have joining us from Carle Health. We've got Dr. Prem Sobti. Thank you so much for being on Being Well.
Yeah, thanks for inviting.
You're so welcome. We love to get to know our new guests. Our viewers get the chance to learn a little bit about you before we start talking about our topic today. Can you give me a little background on who you are, where you're from, that sort of thing?
Yeah, I'm a hematologist and oncologist. That means, I treat diseases of the blood and cancer. I did my fellowship training at SUNY Brooklyn in New York. And after that, I've been at few places. I was in Kentucky, then I was in Missouri for a long time, and I've been at Carle for the last 5 years.
Wonderful. And so what's it like working in rural healthcare in rural America?
I think it has its own challenges and its own, attractions. So I think it's a wonderful opportunity for anyone to serve in rural America. People are nice, the nature is great. So, and there's a less stress, not much traffic. Yeah.
Well, good. Glad that we have a lot to offer here in the Midwest for you, make you feel comfortable and right at home. So today we're going to be talking about GI cancer. Very serious implications with that. Just to kind of lay the groundwork, is this a common area of cancer that needs treated?
Yeah, gastrointestinal cancers are pretty common. The colorectal cancer just by itself is the third leading cause of mortality in U.S. And then we have, pancreatic cancer and then other GI cancers not far behind.
And so does that cover the whole gambit of GI? When you say GI, gastrointestinal, what spots of the body are we talking about?
The esophagus is a borderline zone. It can be in the purview of both gastroenterologists or the thoracic surgeons. Then GI typically means stomach cancer, pancreaticobiliary cancer, liver cancer, small bowel, large bowel, sigmoid colon, rectum, and anal cancer. So all these are part of the GI cancers.
And hearing those diagnoses, I'm sure, can be rattling for a patient, thinking about it being so internal. It might be harder to treat. So today we do want to talk about, treatment options and being able to locate these conditions sooner. So is there anywhere that you think is worth starting at to open this discussion?
Yeah, periodic colonoscopies is a well-accepted strategy for screening for early stage colon cancer, and if you can remove the precancerous polyps, that will cure the condition, and in future one won't develop the cancer. So this is a well-accepted preventive strategy. Unfortunately, we don't have similar strategies for stomach cancer, pancreaticobiliary cancer, small bowel cancers, rectal, and I think rectal is same as colon, or for the anal cancer, we don't have good screening strategy.
So when it comes to colonoscopies, what age range are we talking that we should maybe be scheduling our first one?
I think first one should start around the age of 50. For most of the individuals in general population, it can start sooner depending on the family history. Should start usually 5 to 10 years sooner than the earliest cancer in the family if someone had cancer before the age of 50.
Okay. So we've laid the groundwork that's how we discover those types of cancers. As far as the other parts of the GI system, if they're not easily found through a test like a colonoscopy, how do you typically find those?
Well, unfortunately, many of those cancers are found based on the symptoms, or
Okay.
incidentally they are picked up on the scans.
Okay. Can you elaborate a little bit? I mean, what am I talking about here? I assume it's going to be more than just an occasional upset tummy.
Yeah, let's take example of the pancreatic cancer.
Okay.
If one is lucky enough and the tumor is in the head of the pancreas and presents with a biliary obstruction, and one is deeply jaundiced, those patients are fortunate. That means there's yellowing of the eyes. That's how they present, and they can have a curative resection. On the other hand, if the tumor is in the mid portion of the pancreas or the distal pancreas, they tend to get bigger and they tend to spread adjacent lymph nodes, or sometimes even farther away before the disease is diagnosed.
So that is we've got the colon covered, we've got the pancreas covered. What about stomach cancer?
Yeah, stomach cancer is similar. We don't have a screening strategy for stomach cancer, and if you look at the historical description, it will present with unexplained weight loss, anorexia, but it can present with a variety of other symptoms, abdominal pain, bleeding, unexplained anemia, and some patients will present with a bowel obstruction. They will be having nausea, vomiting because food won't go down, past the stomach.
Mm-hmm. So once I'm somebody who is diagnosed with this, I know every patient's going to be different, but what does a typical treatment plan start to look like for this?
I think for every GI subsite, the treatment plan is different because their natural history and response to treatment, different kind of treatments is also different. So if you want me to summarize, I can start, how we start with the stomach cancer. In the early stage stomach cancers, let's start one by one.
Okay.
Yeah, so the early stage stomach cancers, they are treated primarily with endoscopic resection,
Okay.
or surgery alone. But once they are more advanced and they have penetrated beyond a certain extent into the wall of the stomach and their adjacent lymph nodes, these are still, local regional, stage of the stomach cancer, treated with chemotherapy first, followed by surgery, followed by usually more chemotherapy. For stage 4, stomach cancer, then the treatment is depending upon its molecular profile, we'll come up with a specific treatment. But usually it is chemotherapy plus minus immunotherapy for most of the patients.
Okay. And then moving on.
Then moving on to the pancreatic cancer, again, the very early stages of the pancreatic cancer can be treated entirely with surgery with a reasonable possibility of cure, which can approach up to 20%, based on historical series. But more advanced stages, when the tumor starts to get very close to the blood vessels, the celiac axis, the superior mesenteric, veins or the arteries or the portal vein, once it is close to the important blood vessels, then we would like tumor to be shrunken with chemotherapy before going for the surgery. And following the surgery, usually there's more chemotherapy because the natural history is not so good. So this is for pancreatic cancer. Unfortunately, some patients will have metastatic disease to begin with. They'll be primarily treated with chemotherapy, and depending upon the molecular profile, we'll come up with subsequent treatments, once they have failed the standard chemotherapy options.
Okay.
Then going to the small bowel, these are rare cancers. They are treated usually identical to the colon cancer. And the colon cancer, depending upon the stage, the treatment is determined. If the tumor is confined to the colon or to the adjacent lymph nodes on the scans, and there's no other distant metastatic disease, like in the liver or other parts of the body like lungs. So these tumors confined just to the GI tract, they are first treated with surgery, and with the surgical specimen, we look at the pathologic stage, what it is. If it is confined just to the walls of the colon, and there's no adjacent lymph node which is involved in the mesentery, those patients usually are treated with observation only. Only a subset of those patients, if they have a lot of bad features on the microscopy or clinical presentation, then chemotherapy can be offered selectively on those patients, for those patients. If there are adjacent lymph nodes which are positive, then it becomes stage 3 colon cancer. There's a consensus all of these patients are going to benefit from chemotherapy. So they're offered 3 months or 6 months of chemotherapy, as many times patients have a choice what chemo regimen they want. And we also take into consideration patient's age. If someone is extremely old, we may not give them the most toxic or the chemo containing multiple agents. Just give them a pill, capecitabine, and that may be sufficient for in that scenario. For metastatic colon cancer, we got a lot of treatments, a lot of options available, and we also look at the molecular profile of the tumor, and then come up with a individualized plan.
And so let's say I'm somebody who is going through treatment for any of these. I imagine my digestion is going to be very different than it once was before starting. So what can I maybe expect as far as trying to eat, have regular bowel movements post-treatment?
I think it is different. These post-surgical complications or the risk of having problems is different for each site.
Okay.
There are unique complications following removal of a part of the stomach or the entire stomach, and the problems would be of a different nature if you remove part of the large bowel, and problems would be different if someone undergoes a rectal surgery. I think if you want, I can get into some details. I'm not a surgeon. Let's say you have part of your stomach removed, then obviously one can have partial obstruction, sometimes nausea, vomiting, because the bowels, the stomach doesn't work the way it should be working. And some patients may get a dumping syndrome, that the food just passes too quickly, and then there's a lot of osmotic, load into the small intestines, and patients will have, symptoms as a result. With a large bowel, most of the patients don't have much symptoms as long as half the colon is removed, but some patients will have some diarrhea or loose stools for a period of time until the colon will adjust. If you remove the entire colon, then the patient will end up with a ileostomy. So the small bowel is there, and large bowel is obviously it concentrates all the water. Those patients will have significant output from the bag. Some patients may have high output diarrhea. Pelvic floor problems with rectal surgery. So they are unique things. Usually I don't deal with that. Usually the surgeons handle that.
Sure. Well, and before we got recording, you were talking about how Carle Health has several different tumor boards. Can you kind of talk about what those are, what the function is of those boards?
Yeah, we have 11 tumor boards, and of these, 3 of them, meet regularly. They are for the breast cancer, for the lung cancer or the thoracic tumor board, and the third one is the lower GI tumor board, because we have a significant number of patients, with these cancers. So every week, we meet those. But rest of the 8 tumor boards, depending on the workload, they are usually every other week. So on Mondays, for example, we have a head and neck tumor board, and we also have thyroid tumor board. On Tuesday morning, we have the upper GI tumor board, which includes, disease of the esophagus or the liver or the bile ducts. And then in the afternoon, we have a general tumor board. Anyone can put in any case for discussion. We have a GU tumor board, with the usually it is the cancer of the prostate or the bladder or the genital. That is included in that. And we also have hematology tumor board I think that's once a month. On Wednesday we have breast tumor board. On Thursday we have thoracic tumor board. On Friday early morning we have a lower GI tumor board, and then in the afternoon we have the brain or the gynecology tumor board, or sometimes both.
So they keep very busy.
Yeah, they keep us very busy. each one of us attends at least 3 to 4 tumor boards.
And so with these boards meeting so regularly, is this to discuss the most up-to-date research or findings, or what do you do there?
Yeah, first of all cancer patients are discussed in general in one or the other tumor board.
Okay.
And then everyone gets together, to hear about the case from a surgical perspective, from a medical oncology perspective, from a pathology perspective, radiology perspective.
So that's everybody under one roof?
Everyone
Okay.
on one roof, listening to the case. And then, we come up with a plan, what the stage is and how we would like to treat this patient. Then we present the plan to the patient. And our research team is also listening and contributing, with this. Our genetic team is also, listening and contributing to this. If they think, there's a clinical trial, that would apply to the patient, they will suggest those, and then we'll present all that information to the patient and see, what they want to do.
And so do you present them with multiple options or typically just a best option?
I think for most patients, we end up telling them, more than one option, but we tell them, the tumor board recommendations are based on a consensus, because there's always, not always, but most of the time, there's more than one way of handling the situation, and literature is not clear, what exact treatment would be best for the patient. So that's where the expertise of everyone comes in, and I think it is a win-win situation for everyone. We feel good, we are doing a good job, patient feels good, that everyone has listened to their case.
Sure.
So they're very happy with that.
Well, and being able to have the facts in front of you, I'm sure helps as you're making possibly, a life-altering decision, whether you want to do something more invasive, more aggressive, less aggressive.
Yes.
So as you talk with patients, in the time that you've been in this field, what's it been like for you to be able to advise them through these processes?
First of all, I'm honored to be in this profession. This is very emotionally satisfying, for me and also for anyone who gets into oncology. And it is always beneficial to understand the patient side. What their expectation, what their fears are. So we try to elevate that based on our experience. And some families are highly educated, they have already read up on that, and then they want to verify the things with us. I think
Dr. Google says, but what does Dr. Sobti say?
Yeah. So we help them out too. I think the Google has become very good over time. Many years ago, when the internet was new, we were suggesting, don't go over the internet. But I think for the newer generation, I would encourage them to go on the internet. Good quality information is available from a variety of sites, including research opportunities that may be there at apex institutions or someone doing cutting edge research anywhere in the world. You can easily find that out.
Sure. And so does Carle Health look outside of the organization for those experimental trials or things?
Yeah, we do. Let's say we don't have a clinical trial for one patient. I just had one patient yesterday, and then we found a trial for him that is in Wisconsin, and he's willing to travel there. So their team is going to get hold of the patient, determine the eligibility, present all the information, and so he's happy.
No, the connections that you can make are incredible, and it's also great to hear you recognize that the human aspect of it instead of just a doctor with patient numbers or whatever. You're trying to help dispel misinformation or fears that they might have as they're walking through this.
Yes.
So in the time that you've been in the cancer treating realm, what advances have you seen in technology? I'm sure it's been incredible to watch unfold.
Oh my God. First of all, I joined oncology because it was a cutting edge at that time, the stem cell and all the research. And now we're seeing, the fruits of all that research that has been taking place for the last, several decades now on the stem cell, for a better understanding of the molecular pathogenesis of different cancers, more understanding of the cellular pathways. First of all, 20, 30 years ago, the only treatment option available was chemotherapy. And by the time, we reached year 2000, it was clear that the chemotherapy has a certain role to play, but, no more advances are going to happen because whatever it could have done, probably maximize the survival by that time. So after that came a better understanding of the cellular pathways. So a lot of pathway inhibitors, came in and they started changing the things very quickly. And now for the last 10, 15 years, we have immunotherapy, as a game changer. It is working great for a variety of cancers. It has done wonders in cancers like melanoma and has deep impact on a lot of other cancers like colorectal and lung cancers. And I think the list is pretty long.
Mm-hmm. If I'm somebody who is maybe not familiar with immunotherapy, I know it's not the newest kid on the block, but do you mind explaining what that is, like how it works and how it differs from chemo?
Yeah. Immune checkpoint inhibitors, in simple terms, they remove the brakes, from your immune system. So your immune system, which was unable to attack the tumor, now is able to attack the tumor. So you're removing the brakes. Unfortunately, there is a downfall. Some patients will have serious side effects, but usually it is far less than 5%, maybe 2-3%. Your own immune system can attack your own body. Mm-hmm. And two organ systems are preferably at risk. One is your colon. It causes colitis and diarrhea. The other organ system at risk is your endocrine system. It can cause endocrinopathy, usually hypothyroidism. It can block the pituitary, deep in the brain, or the adrenal glands. So this is what we commonly find. But endocrinopathies are not very debilitating. You can keep going and keep doing the treatment and just replace the hormones. But some of the other side effects can be really severe.
Well, and as we're in our last couple minutes here, as somebody who treats these GI conditions, you had mentioned, I believe, colitis, mm-hmm. and there's other, all sorts of stomach issues that one can experience. So do you take those things into consideration as well when you're in that, the kind of war room with the board trying to decide how you want to treat? You have to be cognizant of, maybe they can't process nutrients as well, or those sorts of things?
Yeah. We look at everything about the patient. We look at their socioeconomic status, see, what background they come from, mm-hmm. what kind of help they will need. We look at their other comorbid conditions. Let's say, someone already has colitis, like a Crohn's disease or ulcerative colitis.
Mm-hmm.
We're not going to give them immune treatment.
Mm-hmm.
We're trying to avoid that. So the underlying, or the background conditions have a deep impact on what would be safe for the patient. So we review all those things.
In our last few minutes here, is there anything about this topic in general that I didn't ask about that you think it's important for a viewer at home to know?
Yeah, I think everyone is looking for hope, and one should always have hope, with the modern medicine. Some cases which appear even hopeless, they've got advanced stage 4 disease, you never know. Some of those patients can respond miraculously to the newer medications. So I will tell patients, don't give up hope. As long as it is reasonable, we should keep trying. Mm-hmm. And you never know, some patients can have a deep and prolonged response, from the modern treatments.
And how important is it to also maybe prepare the family too for what the ramifications of treatment are going to be?
I think that's part of the education process.
Yeah.
Most of the time, the family members will come with the patient, so they are part of the entire team, from the other end, listening
Sure.
to it. So when we are telling the side effects of the treatment or the treatment itself, what the probability is, how, for and against, either it will work or not work. So they are listening to all that, and that's extremely helpful. So we make sure that the family understands, because they are the second set of ears. They're going to reinforce the same thing, when they go back home.
Yes. So in our last minute or so, are there any other stories that stick out to you of how treatment has helped somebody get their life back?
Well, before I came here, I had a woman, and when I saw her the first time with colon cancer, it had replaced the entire liver, and she was deeply jaundiced. In that era, we thought, she was going to die, and she will never make it, because none of those patients, ever made in the past. But she responded beautifully to the chemo. And when I came here, she was still on chemo every 2 weeks, mm-hmm. going on for 7+ years.
Wow.
And she was very happy with that.
That is wonderful to hear. Dr. Prem Sobti, thank you so much for coming on Being Well. I appreciate your time.
Yeah, thank you. Thank you, Lacey.
And we thank our viewers for joining us for this episode, and we hope that you will join us in the next one.
Thank you.
Carle is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carle is always at the forefront to help you thrive.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
This is you, and you are why we do what we do. Because the way you feel matters. Sarah Bush Lincoln. Trusted, compassionate care.